So unless I say something's different, just assume it's 40. And then make sure that your blue and your green are both lit, meaning that you're locked in. Right? If we weren't, it would be slightly off. And then for this one, you don't have to mess with removing the cassette or whatever, because it's digital. But if you were working with the table, yes, you would have to. So we're gonna
digital too.
It is digital, but you do have to like change it from lengthwise to crosswise or whatever.
Do you have to
But
change
this
the grid as well? If you're shooting?
Grid, no. But for the wall bucky, it will automatically fix itself once you mess with the collimation.
But we're only working with the bucky, right?
Yes, only upright for this portion. So we're gonna start off with the PA ribs. There's about 12 or 13 positions today. So PA ribs, who wants to be my patient? Anyone? Alrighty. So it's very similar to a chest, because what we need to see is in the anatomy right here. So we want to have them stand upright, PA position, and what we're gonna do is place the top of our IR, or the top of the light field, 1.5 inches above her shoulders. So let's bring it down. So same like the chest, just like a chest. Okay, and then make sure our bucky lines up. Make sure her MSP is lining up with the central ray. And collimation is going to be 14 by 17.
Okay.
Okay, let's see. Her hands are going to be on her hips, just like we do for a chest. And roll your shoulders forward. Perfect. Centering is still going to be a T7, just like a chest. And breathing instructions is going to be similar to a chest also. Take a deep breath in, blow it all the way out. Take another deep breath in, hold your breath, x-ray, you can breathe. So it's pretty much like a chest.
Okay.
The only thing that the image will look different to a chest is because the bones will look very bright, because the technique's gonna change. So that was our PA ribs. You can relax. We also have AP ribs. We'll do a above diaphragm and a below diaphragm for the AP ribs.
Always two?
Not always. For patients that are small, like Carla, we can get all of her ribs in one shot. But for somebody that was like asthenic and very long torso, like Cody, we would have to do above diaphragm and below diaphragm. So.
And you would determine that after the first x-ray, right?
Yeah,
You could see
like
how
if
many-
I was a tech, I would do above diaphragm first. If I didn't get all 12 ribs, then I'll do a below diaphragm.
Okay.
Okay, so AP ribs, she's going to be in an AP position. Top of IR, still gonna be 1.5 inch above her shoulders. MSP's center. Of course, if the patient has a bra or jewelry, you would have them remove it. So, above diaphragm, we're gonna focus on the light field being 1.5 inch above her relaxed shoulders. The arms can be off to the side, it doesn't matter. And then for above diaphragm, we want to suspend after full inspiration, because we want that diaphragm pushed down. So the breathing would be just like a chest. Take a deep breath in, blow it out, take another deep breath in, hold your breath, and breathe. So that would be for above diaphragm.
So she's holding.
Yeah, she's gonna be fully inspired. I'm sorry, I can't talk with this mask on. Below diaphragm, we want the diaphragm pushed up and out of the way. Do you know why?
But you want
To get the 11 and 12?
Yeah.
Yes, to get the bottom of the 11 and 12, we don't want the diaphragm in the way, we want it pushed up. So what will we do with our respiration? Suspend after full expiration. So deep breath in, blow it all the way out, hold it out, and then x-ray. And then, of course, since we're doing below diaphragm, our top of the IR is not gonna be here anymore, right? It's actually going to be by her axilla.
The top of the leg.
Top of the light at the axilla. Okay.
Top of the light at the axilla. In the book, it also says bottom of the light should be somewhere around the iliac crest. But for me personally, it's easier to look at the axilla.
So iliac crest as opposed to as is?
Mm-hmm.
Okay.
Iliac crest. Because we just want those bottom ribs, right? We don't need all the way down. So let me match this.
Then it just turns into a supine.
Right.
Caving.
Like a caving.
Yeah.
Mm-hmm. Alright, so MSB still centered. The only thing that changes is our breathing instruction, which is take
Suspend
a deep breath
respiration.
in, blow it all the way out, and then hold it out.
And that is what?
Below diaphragm, AP ribs.
But what is this called? Suspended respiration?
It'll be suspended after expiration. Mhm. Collimation is still gonna be 14 by 17.
No, it was
No,
for.
let me fix that.
Oh, that's-
So that was our PA ribs, AP ribs above diaphragm, and then AP ribs below diaphragm.
And above and below diaphragm have different breathing instructions?
Mm-hmm, yes.
So above is like a chest,
Mhm.
and then below is
Okay.
suspended after expiration.
Yep. So now we have oblique ribs. This can get a little bit tricky. So whenever you guys get a rib as an order, you might most likely see bilateral ribs, meaning they want to see the left side of the ribs and the right side of the ribs. But we're gonna do both obliques, like either a RPO or LPO. The important thing to remember is that you're not gonna get both sides of the chest in the image.
Even though it says bilateral.
Yes, bilateral just means you're gonna
Both
do
sides.
both obliques. It doesn't mean that you need to get the full chest in one shot. It's very rare that you will get it on a patient. They have to be very, very narrow
To get both sides.
to get both sides.
Oh.
Mhm. Some techs may argue with you, but if you're doing both obliques, it doesn't make any sense. So, we're going to start off with the RPO and the LPO. So, let's see. We're going to rotate you 45 degrees towards
So we're doing the RPO first?
RPO. Let me rest. You still want the top of the light 1.5 inch above her relaxed shoulders. We're just obliquing the patient. Okay, 45 degrees. Separate your feet a little bit. That's good. And then whatever arm is near the IR, you want it above, like on her head. And the other arm is going to be on her hip, kind of like in a sassy pose.
Hand this way?
Hand on your hip, just like that. So, this line right here is going to be entering between the MSP and the surface of the body that's closest to the IR. So step back a little bit. Keep going. Oh, come back just, yes, right there. So this line, you want it not right at the MSP, you want it off to this side. Between the MSP and, what is this plane? MCP. So step back just a little bit.
So it's barely offset?
Like off-centered to the side that's closest to the IR. This is an RPO. And then for collimation, you don't need all of that space. Let me fix your.
So with an RPO, you're looking at the right ribs or the left rib?
That's the left, right?
The RPO is gonna look at the,
The left.
The right side?
no, it is the right side.
I thought it was always the opposite.
Mm-mm.
Well, that's the side against the IR.
Yeah.
Yeah, the right
Okay,
side's
sure.
against the IR, so you're looking at the right rib
Yes,
with an RPO.
yes.
And
But where it gets confusing is, we know that we're looking at the right side, but are we looking at the posterior side or the anterior
the
side?
posterior side.
Yes.
So you would have your marker flipped?
You can, but you don't have to.
So you're looking at the posterior side like this?
Yes,
Because it's closest
'Cause-
to the
because it's
IR.
closest to the
Ah,
IR.
okay.
Mm-hmm. Anyone have their right marker? You can put it anywhere in the light field.
So for test out purposes, would you prefer we do like a PA like that, or the marker?
Oh, you can do it either PA or AP.
Okay.
Mm-hmm.
So
I'll
we
take
won't
both.
get- Okay, we won't get one.
I'm not gonna be crazy about that, as long as you use your marker. So that was our RPO. For the LPO, I just wanna say, because we're looking at the right side, even if you clip this part, it's okay. Cause we're gonna do the other oblique. So go ahead and get into an LPO. So the left arm is gonna be on your head. This one's gonna be on your hip.
So if you have these two, there's no reason why you should remove the tube. You should just be moving your patient, right?
Yeah, once you have your tube set up 1.5 inch above her shoulders, it's at 40. Only thing that needs to move is the patient.
Okay.
So step back a little bit for me. Keep going. Keep going. Right there. Hit the light for me, Jay. No, right here.
Sorry.
So you want that line off to the left side of the MSP, right? Between the MSP and the MCP. Yeah, let me just make sure she's in 45. Perfect. This much of space is, you can collimate in a little bit, but that should get you your left side.
And what are breathing instructions for these?
So for these, you also have above diaphragm and below diaphragm, because remember, patients can be very tall. So for above diaphragm, it's going to be after full inspiration. You want that diaphragm down. Below diaphragm, you want that diaphragm up and out of the way. So it's going to be after full expiration.
So the same
Suspended.
as the PA.
Same as the AP.
AP.
I mean, AP, yeah.
Mm-hmm.
Okay.
So your image should look something like that,
Okay.
where that left rib is going to be elongated.
The way she's positioned now, would we still get that first rib?
Let me see. Bring this arm down. So when you start off, if you have your top of the IR 1.5 to 2 inches above her shoulders, you should be able to get that first rib.
Okay.
Mm-hmm.
Good question. Will they ever ask for PA? And then will they ask for an AP as well?
For the ribs? So it really depends on the hospitals. I know some hospitals, like if they order bilateral ribs, it's automatically known that you have to do a PA chest and then an AP of the ribs also. So it really depends on the hospital, what they're looking for.
So that would be 3
You would do a PA chest, you would do an AP of the ribs, maybe upper and lower depending on the patient, and then both obliques. So you may end up with 1, 2, 3, 4, 5, 6, 7 pictures if you do upper and lower for the obliques. And
How do you know if they say that they want, well, that would be the bilateral.
It's gonna say bilateral. Very rarely they'll say unilateral ribs if they're specifically looking for injury on one specific side.
So on that note, let's say somebody comes in, they were in a motor vehicle accident, they have a suspected punctured lung. Would they do all of that and then throw some like abdomen decubitus or or like a chest if you is?
They could possibly throw that in. It really depends on the radiologist and what they want.
I mean, you would always just go by what the session numbers say on the
Well,
paper.
yeah, I was just saying like what are the sort of views that we could suspect or like expect rather?
Anything.
Anything, yeah.
Everything and anything.
Like if they come through the EC and say, "Oh, my arm's hurting," they don't even have to suspect a fracture. They'll just order it just for fun. That's just how it is. So that was our AP obliques, right? We did our RPO and LPO. With our AP obliques, what side are we looking at?
The side closest
The
to
The
the
side
IR.
closest to the IR.
And we're looking at the posterior side.
Yes. So when we're going to do PA obliques, that concept is going to switch on you. So don't get confused yet. Go ahead and get into a PA. So this is what we call our anterior obliques, right? Because this side is touching the IR. We're gonna either do an RAO or an LAO. So the way that I remember is that anterior away, meaning, get into an RAO for me. So with an anterior oblique, the side that's away is gonna be the side of interest.
So the left side?
Yes. So your left anterior ribs is going to be the side of interest because that's the part that's going to be elongated. Look at this picture.
See, I remember it was the opposite side for some reason.
So the way that I remember is anterior away. Anterior oblique, the side that's away is going to be your side of interest. Okay?
So anterior is always gonna go side that's away, and that's the one that's the interest.
Side of interest. So right now, what position is she in?
Sorry.
Oh, no, you're good.
She's in anterior,
Specifically,
right?
RAO.
Yeah.
So her left side is our side of interest. Her left
anterior.
front side is our side of interest, right?
So would we put the right marker or the left marker?
Well, you would
I
still
would
put
use the left marker because that's the one that's
The side
going
of
to,
interest?
yeah. Let me get on this side. So, yep, so this arm is going to be up on the
But I
up
thought
view
you
right here.
always put the marker, the side that's touching the, yeah.
So, if you look at the picture here, you see that the right side is cut off.
Okay.
So I would not even waste time putting my right marker.
Okay, cool.
Mhm.
What is the purpose of this exam, or like what's the benefit of doing this one over the RPO?
So if they're specifically looking for injury on her left front side of the ribs, this is the oblique that you want to do.
Okay.
I would say a lot of techs don't know the difference between an RPO or an RAO, but you should know. They'll just be like, oh yeah, just do both obliques. They won't even care which specifically you're doing. Someone be my light person. Okay, so in an RAO, we want the line away from the MSP and then midway between the MSP and the MCP. So it's entering right there, correct? Make sure that she's in a good 45. Turn her just a little bit. Separate your feet. Bring this right leg closer to the IR. Perfect. 45 looks good. I'm gonna come around this way. Step back a little bit. Keep going, keep going. Keep just a little bit more. Yes. And let me see, my collimation needs to be 14 by 17. Okay. 45 looks good right there. We have enough space past the shadow of her chest to put our left marker. Lift that head up out of the way. We don't want the chin in the first rib. Okay, we are ready to shoot. So if we're doing above diaphragm, which this is, take a deep breath in, blow it all the way out. Take another deep breath in, hold your breath, x-ray. And then what do you think we would do if we were to do a below diaphragm in this position? All we need to do is, bring this down to the axilla, right? We know that there's no ribs past this, right? Bring the bucky down to match. Okay. Put our marker, and then our breathing instruction would be suspended after full expiration. Alrighty, you can relax.
Is there any mandatory?
Mandatory, I would have to ask Wilson. So those were our rib positions. Any confusion on those?
Do you think it'd be reasonable for Mr. Donahue to ask, like, how would you be able to tell the difference between these two images and figure out which one's RAO, which one's RPO? Like, because the only thing that I can tell is that in the RAO or LAO, you can see the clavicle a little more pronounced at the top.
I think we would have to ask Mr. Donahue. I think he's gonna put that in his